This is imaging-based approach to NAFLD. Whenever patient comes with suspected non-alcoholic fatty liver disease, we first clinically assess that and liver function tests are ordered. Then, initially, ultrasound is advised. If ultrasound is normal, we ask the patient to come for follow-up if there is high risk. If there is fibrosis present, we grade them into 1, 2, and 3. That is stage 1, mild, moderate, and severe. If fatty infiltration is present and patient has low risk of fibrosis, then again we ask patient to come for follow-up. If there is high risk of fibrosis, we do liver elastography which stage the fibrosis. And if there is low risk, we can put the patient in monitoring. And if there is high risk, there is management and urgent interventions are required. These are the common indications when liver imaging is advised, like clinical indications such as hepatitis, alcohol-induced suspected NAFLD, for screening obese patients with diabetes mellitus, patient with metabolic syndrome, and for liver donor patient screening. And we also use this for follow-up imaging of treatment and post-transplant patient. There are different modalities available to detect fat and fibrosis. Then why are we using ultrasound? Because it is highly accurate, cost effective, easily available, and it is non-invasive method. When the patient comes for liver imaging, we usually start with grayscale imaging. We assess liver size, echo texture, portal vein diameter, its flow pattern, gallbladder, common bile duct, and spleen. As we can see that this is normal liver. Its echogenicity is similar to or just slightly higher than kidney. When it progresses from grade 1 to grade 3, echogenicity increases. In grade 1, vessels and diaphragmatic surfaces are very well visualized. As we progresses to grade 2, vessels are indistinctly visualized, and we progress to grade 3, even diaphragmatic surface is not well visualized. But as we discussed, this is just qualitative imaging. This is just visual representation. So there is need to quantify the PET, how much percentage of the hepatocytes are affected. So this Mindray state-of-the-art Mindray machine has provided us this USAT value, that is ultrasound attenuation. It measures the fat quantitatively, and fasting is not mandatory if the measurement is taken alone. Fasting is mandatory if we are doing fibroscan alongside fat quantification. Patient should be able to hold the breath for at least few seconds. This box is placed perpendicular to the liver capsule and at least 2 centimeters below the capsule. Total 5 readings are taken and median value is calculated. Here I have shown that uh, as you can see that box is at least 2 centimeters below the liver capsule, and I have taken the measurements, and machine has generated total median value of total 5 readings, which is 0.39. This is standard cutoff criteria to grade the liver fatty infiltration. If it is less than 0.53, it is normal, and if it greater than 0.83, it is suggestive of S3, that is severe steatosis. Here I have put some images for representation. The first image, we can see that all the vessels and diaphragmatic surfaces are well visualized, and USAT value is 0.58. So this is grade 1 fatty liver. Here we can say that vascular margins are indistinct and diaphragm is well visualized. USAT value is 0.72. It is suggestive of S2, that is moderate steatosis. And here even diaphragmatic surface is not distinctly visualized, and USAT value is 0.84. It is suggestive of severe, that is S3 steatosis. Another quantitative method to measure the liver fat is hepatorenal index. We compare the echogenicity of liver to kidney, and this improves the objectivity. Here I have mentioned cutoff criteria for interpretation. Now we will move forward to liver elastography. There are various methods we can detect the liver fibrosis. First and foremost, gold standard is liver biopsy. It is most accurate, but it is limited as it is limited by the fact that it is invasive procedure. There is risk of bleeding, pain, and infection, and sampling errors are possible, and it is not as easily reproducible. Then comes the role of liver elastography. It is non-invasive, quick and fast technique to measure liver stiffness. Liver stiffness depends on the stage of fibrosis, and this will guide us to provide further treatment and prognosis and surveillance. Here I have shown the basic principle behind ultrasound sonography. As you can see that this is ultrasound probe. Acoustic waves are transmitted into the tissue. This tissue in turn generates the shear wave. Velocity of this shear wave depends on the fact that how stiff the tissue is. If the tissue is stiffer, the faster waves are generated. We calculate the velocity of these waves and convert it into kilopascal value. Uh, there are two types of elastography. Transient elastography, traditionally we call it as fibroscan, and shear wave elastography. Transient elastography is a quick procedure and it requires mechanical waves, and it is more operator dependent, and there is no real-time B mode image in fibroscan. Then there is shear wave elastography, in which acoustic radiation force is implied, and it is not as less operator dependent, and real-time B mode imaging is also available, but it takes slightly longer time than fibroscan. Shear wave elastography is of two types, point shear wave and 2D shear wave elastography. In point shear wave elastography, only single point measurement is taken. In 2D shear wave elastography, multiple measurements are taken from multiple regions of interest. Uh, why don't we use MRI for screening? MRI is gold standard non-invasive, highly accurate method, and it is accurate. Even sonography is as accurate in MRI in earlier stages. However, MRI is more accurate in stage 4. MRI does the whole liver assessment, while the sonography there is limited sample area. But disadvantages of MRI is that it is not as easily available as sonography. It takes longer time and it is costly. Now we will discuss examination technique. At least 4 to 6 hour fasting is mandatory for liver fibroscan. Patient should be able to hold the breath for at least few seconds. Patient is advised rest for at least 10 minutes before we start the examination. And total 10 valid measurements are taken and median value of which is calculated. I have shown the how to take the measurements here. Here, I have put the measurement box at least 2 centimeter below the liver capsule. Patient is asked to hold the breath and I have taken measurement. Here we can see that this is MSTB index. Okay. It should be at least 4 to 5 star, and there is another reliability index which should be more than 80%. Total 10 measurements are taken and median value of which is calculated. Here I have shown the importance of putting the box away from the liver capsule. If we put the box very near the liver capsule, artifacts are present and value may come very high. These are some reliability criteria this machine gives us. As we discussed, here there is motion stability index. It should be at least 4 to 5 star so that we know that it is reliable, accurate measurement. And this is reliability index, which should be more than 80%. The most important reliability criteria is IQR by median, that is intercontinental range by median ratio, which should be less than 30% if we are taking 10 measurements in kilopascal. These are some recommendations for interpretation. Previously, we were using Metavir score to grade the liver fibrosis. If it's less than 7, it was normal, and then progressively mild, moderate to severe fibrosis. Nowadays, we are using the standard rule of 4 criteria to categorize the patient, which is vendor neutral also. If it is less than 5 kPa value, that is high probability of being normal. Here score is 5, 9, 13 and 7. If it is less than 9, it rules out compensated advanced chronic liver disease. Between 9 to 13, it is suggestive of compensated advanced chronic liver disease, and if more than 13, it is rules in compensated advanced chronic liver disease, and more than 17 value suggests that patient has high risk of developing clinically significant portal hypertension. Here I have shown one image case with patient with known case of chronic liver disease and portal hypertension. This is liver image which shows that parenchyma is coarsened, there is surface irregularity, and there is patient has developed ascites also. There is dilatation of portal vein with splenomegaly, which is suggestive of portal hypertension. Then we have taken the KPA value, it comes as 11.3, which is suggestive of compensated advanced chronic liver disease. Here I have shown another patient which came from routine health screening and he had high cholesterol level. As we can see that liver vessels are well visualized, then USAT value is taken and KPA measurement is also taken. This is our standard report format which we give to the patients in case the patient comes with liver imaging. It has multiple parts. First, we mention the clinical profile indications. Then we have mentioned the grayscale ultrasound findings, liver along with CBD findings, portal vein, hepatic vein and gallbladder. Then we move forward to liver fat quantification. We have mentioned the USAT value. We have also mentioned the IQR by median ratio, which is less than 15%. So it suggests that it is highly accurate measurement. And these are the cutoff values, which is suggestive of S1, that is mild steatosis. Then we move forward to next segment, that is liver fibroscan. Here median value is 5.6 kPa, so it rules out compensated advanced chronic liver disease. We have also mentioned Metavir score, which is optional, which is suggestive of normal to mild fibrosis. And finally, we have concluded the case by showing that patient has grade 1 fatty infiltration, S1, that is mild steatosis, and no risk of compensated advanced chronic liver disease. Structure elastography reports help us in prognosis, follow-up, treatment options, and ensure consistency across reports. There are several limitations which we face during liver elastography. In case of acute hepatitis, postprandial hyperemia, intense physical exercise, hepatic congestion, infiltrative disease, KPA value may come higher than normal if we are doing the scan, and in case of ascites, KPA value may become altered also. These are the standard follow-up criteria. If there is stable or low risk patient, we can do follow-up at 2 to 3 years. In case of moderate risk, we can do the follow-up at 1 to 2 years. And in case advanced disease, follow-up is mandatory at 6 to 12 months. Follow-up can be done earlier if there is sudden rise in liver enzymes, clinical deterioration, if there is any change in treatment. These are some frequently asked question I want to discuss. What is difference between MR and USG elastography? MRI, as we discussed, MRI is more accurate in earlier. USG and MRI is accurate in earlier stages, but MRI is limited by the fact that it is costly and not as easily available as ultrasound. Why fasting is recommended before elastography? Because postprandial state increases the hepatic blood flow and KPA value may come higher than normal. Can elastography replace liver biopsy? No, it cannot completely replace the liver biopsy because liver biopsy is gold standard, but it can reduces the frequency and need for liver biopsy. For follow-up patient, we have often get the question that how much change in KPA value is considered significant. At least 10% change should be considered significant. In conclusion, steatosis and fibrosis are in earlier cases they are reversible. So we have to detect the early fatty infiltration and early fibrosis, and early detection prevents further complications, cirrhosis, and for all this standardized reporting is necessary. Apart from this, these are some guidelines and advices you can adopt to keep your liver healthy. Eat a balanced diet, stay hydrated, regular exercises, regular screening, use medications wisely, get enough sleep and lifestyle modification, and of course, diet. Thank you all. हाँ. चलो मैं जरा चालू होना फिर करती हूँ. Screen बंद. Screen off. now. When patient comes for liver imaging. Mute किया थे thanks. Okay. Here patient has come for liver imaging. I start my examination by doing grayscale ultrasound. This is left lobe of liver and this is right lobe of liver. As you can see that vessels and diaphragmatic surface are very well visualized. This is IVC. Then we assess gallbladder for any stones or chances of cholestasis. Here there is portal vein and at above that there is common bile duct. I have asked the patient to turn on the left side to take the measurements. This is portal vein, diameter is normal and flow pattern is also normal hepatopetal flow. Hepatic veins are also showing good flow. Then I am measuring common bile duct. It is not dilated. There are no evidence of any stone or stricture within common bile duct. First, I take the USAT measurement, that is ultrasound attenuation. Liver size is normal. And we can see that liver ecotexture is fairly normal. Homogeneous normal parenchyma is seen. Here I am taking measurements because motion stability index shows 4-star and reliability index is also good. Here we can see that mean value is coming as 0.51. Reliability index is also good and motion stability index shows 4-star, which suggests good imaging and accurate findings. I take multiple measurements. Total 5 measurements are taken. Here again, motion stability index is good. I am rejecting this image because reliability index was not good. Here I have taken another measurements in which motion stability index and reliability index are well. Here mean value is 0.48. I am taking another measurements now. Okay, I am rejecting these images because reliability index is less. I am taking another measurement. Here we can see that everything looks good and mean value is 0.47. So machine has generated the median value, which is 0.50, which suggests there is no steatosis, it is normal. IQR by median ratio is 5.0, which is suggestive of good accurate images. Now we are moving forward to another measurement, that is hepatorenal index, in which we measure the echogenicity difference between liver and kidney. I have put one ROI in the kidney cortex and one ROI in liver. As we can see that echogenicity is almost similar to kidney and value is also coming as 1.0, which is suggestive of normal. 0.95 mean value, it is normal. I am taking total 5 measurements. And machine will calculate the median value of this 5 measurement and also present IQR by median ratio. Here we can see that median value is 1.0, which is normal, and IQR by median ratio is 3.3%, which suggests accurate measurements. Then I am moving forward to elastography part. Here I have put the measurement box, avoiding major vessels and any focal leisure if any. I am putting box away from the capsule. I am asking the patient to hold the breath and then take measurement. RLB index is low, so that I am rejecting this image. I am taking another measurement. Here we can see that motion stability index shows 5 green stars and RLB index is also good. So I am taking measurements here. Again, we can see that there are artifacts. So because the box is placed very near to the capsule, I am taking measurements again. Motion stability index is good. RLB index is also good. So I'm putting the circle here, which shows the med value 4.9. I have taken multiple measurements with a good stability index and good reliability index. Total 10 measurements will be taken. So I have taken 10 measurements here, and machine has generated median value, which is 5.0, and it suggests that there is no fibrosis in this patient. We also see IPR by median ratio, which is 9.6%. It should be less than 30%. And if we are taking measurements in millimeter per second, the IPR by median ratio should be less than 15%. Here it is 4.6%. That suggests that we have taken accurate measurements. Here you can see that reliability index is 100% in every case. Finally, I assess by saying the spleen on this side. I assess spleen for any evidence of splenomegaly for splenic vein dilatation, and I also screen the whole abdomen to look for any ascites if present. Okay, thank you.
I think that was a really beautiful session on liver assessment. And something personal that I wanted to share about Leda ma'am is, of course, she is clinically gifted, as we have all seen. But I have always seen her work because we work on the same floor sometimes. So, quiet confidence are the two words that I think about when I see her, because she, ગુજરાતીમાં કહેવત છે શાંત પાણી ઉદા. She is the embodiment of that. And there might be hundreds of patients, and you will still see the same quiet confidence on her face that you see in the morning and see in the evening. So thank you for that. And
Thank you, ma'am.
next time that and how we can learn that from you. Especially, I want to learn that. Next up, my father always used to tell me that the job of radiologist is similar to that of a wildlife photographer. And for wildlife photographers, their equipment, their camera is just as important to capturing the wildlife. So today, we're doing this talk in association with Mindray, and they are a great sonography company. And we've been using their ultrasonography machines for a very long time now. So from their department, we have Dr. Virat Kulanki, who will be enlightening us a little bit about the different new modalities that they have on their machines. And luckily, coffee is also here. So, do feel free to take that. And after that, we'll move on to the next talk by Dr. Jeevan. Thank you so much. You can like stylus. Stylus. It's not going inside. One second, one second, one second. Okay. So, first of all, very good afternoon, all. Thank you so much to GIC Prime. First of all, I would like to thank entire team for putting so much efforts, and we are here today for the CME. Thank you, Dr. Dinesh sir, Dr. Ankur sir, and our team of Dr. Radiologists who have presented very nicely and prepared very nicely. So much of efforts are given towards putting into this, I mean, whole of this CME, Dr. Heta and Dr. Jinal ma'am, and our Dr. Chairperson, who are Dr. Ankur Shah sir and Dr. Diva ma'am. Special thanks to Anokhi ma'am. I think you made all this possible and with your all efforts. So thank you so much. And of course, our divine blessings are always there by Dr. Hemant sir. We all really miss him so much. Today, I will be sharing a small presentation of Mindray's journey and how what technology we are bringing to this fraternity. So our presence overall in terms of our global presence, we are present in more than 100 plus countries, and we are the most fastest growing company, as you can see that where are we standing here. So we are very proud to associate with also very fastest growing radiology center, which is GIC Prime. And this is our whole of the equipments, the range of our basket ultrasound baskets, ranging from our portable systems to our cart-based systems. You can have a look at that. And we are coming up with more than, even 1 CR plus of the equipments now going further in the premium segment. These are our two flagship products, and across India, we have more than 1500 plus installations of Resona and Nuva i9. So we are very proud to say that even in GIC Prime, we have more than two systems of i9. And this is last year, I think Dr. Anokhi would remember this day. We were at AOCR and we have celebrated our thousands of first thousand I9 across India on, I think, January AOCR 2025, and Dr. Hemant sir and along with the entire IRIF fraternity have given us a lot of blessings and wishes. So, coming to the technology part, our both Resona i9 and Nuva i9, they are powered with ZST Plus technology, and this technology is there for the superior imaging performance. It has iClear Plus, it has HD scope, and what before going into this details, I would like to emphasize that what Dr. Anokhi told is very important. That for a radiologist, machine is everything. They have to give the best of the image
on the screen, and how that's possible with all these technologies. Otherwise, if we have all this off and we have seen the previous machines, so those kind of beautiful images that we are seeing with high resolution probes and high resolution technology is not possible. So we have the exceptional imaging technology, that's iClear Plus, HD Scope, UMA, glazing flow, all available in our i9 equipments. And our ultrasound solutions, they are multi-parametric, so which gives you contrast, elastography, and fatty liver lab. And also, we have the solutions for breast, thyroid, MSK, vascular, prostate, OBGY, as well as the pediatric treatments. Also, a lot of AI solutions are there, which caters all this GI, OB-GYN, pediatric, and cardiology applications. So we already saw this multi-parametric fatty liver lab, which comprises of the USAT, which is fat quantification. So staging of liver steatosis. Then comes this HRI, which again is an aid to this liver steatosis. And also we have this LTI, which gives you the which processes the backscattered imaging and speckles, and also it provides you the information about the liver steatosis and staging of that. So the cutoff values are there, and you have less than 5%, less than 34%, and less than 67%. Overall, this information will give you the information about the fatty liver. Also, as I mentioned, we have hepatorenal index, which works on this RF data, and it calculates the liver as well as the renal cortex ratio. And there are again the cutoff values, which will give you the information about the fatty liver. So there is a liver texture index. So that again works on the backscattered imaging. And again, it gives you the information about the steatosis from mild to moderate. We have very important technology, which is ultra microangiography, and this again, because it is based on the ZST plus platform, it will give you the information about all the tiny vessels. If you see, we have the CUMA, PUMA, and SUMA. All these three are available with your color imaging, and all the subtle vessels will be picked up very nicely. So here, if you see, there is an image of the thyroid, there is an image of the kidney. All these acute vessels are also picked up very nicely. Also, you can see the imaging of the kidney with a linear probe. So that also gives you beautiful imaging with your ultra microangiography. This works in all the probes and all the applications. So whether it is linear probe, convex probe, TV probe, or any of the applications like OB-GYN, it works in all the applications. So as I mentioned, you see the image of the kidney, it looks exactly like a book picture. So all these acute vessels, they are picked up very nicely with this ultra microangiography. So overall, our i9 machine, it is a machine which is whole package, shared service package, which gives you an information and technology for abdomen, breast, thyroid. We have smart breast, we have smart thyroid. So that will give you the automatic analysis of birates and thyroids. We have MSK, we have expanded our applications for point of care, urology, cardiology, vascular. All these things comprises in a one package that is for i9. And these are some of the images which are scanned by i9. So that was about i9, and that's our flagship product. We are selling it left and right across India, and all the radiologists have trusted this product in their clinics. Now we are coming up with, I will take 5 more minutes and show you where Mindray is growing in terms of technology. So we are coming up with Resona A20, and that's a machine which is completely different in terms of technology, and that's a proprietary conventional beam formers. So that's AIT technology, the acoustic intelligent technology, and this is the new technology which we have acquired and on which we are working. So it has three pillars. First, definitely is the data on which we are working, acoustic intelligent technology. That we have changed the probes and the probe technology also. Our probes are now based on the free wave transmitting and receiving technology. Then comes the computing part, which gives you the very super fast resolution as well as the information and performance, and that is because of this hyper parallel computing. And third is the algorithm, which definitely is also unveiling the optimum and robust details. So it gives you the free image quality processing technology and free beam forming technology. So all together we are getting wonderful imaging in terms of all these applications. So they are these free wave matrix probes, and that is our 1-7 probe. So you can see how nicely the depiction of the hemangioma is there. Also the liver lesion at 15 centimeter is also seen very nicely. You see this, you are able to see the hair follicles, and that is because of our 33 megahertz probe. So this is such a tiny probe, and that will give you the resolution like this, very superficial and very good resolution. And that is also the median nerve artery. So that also gives you a nice resolution with our L33 megahertz probe. And we have also come up with this matrix probe, which is from 5 to 80. So this is some images of the breast. So this free wave transmitting and receiving technology, you can see how conventional sampling is there and how the free wave high frequency sampling is there. So it shows the difference. All the fascicles and are seen very clearly with this new technology. You can have a look at this as well. A small lesion in the portal vein is also seen very clearly with our free beam technology. And this is something very interesting, HD scope plus. So if you are zooming this particular area is seen simultaneously on the right side of the monitor and in such a big way with a high resolution. So that will give you a lot of information about the small and tiny lesions, and it will give you the more enhancement of the texture and tissue delineation. So these are some of the clinical images of the ultra microangiography. So gives you super good resolution. And this is something which is now growing. So even I got a call from Dr. Diva ma'am also, that she also wanted to work on the contrast. So these are some of the super resolution contrast imaging. So that gives you information about this focal liver lesion and transplanted kidneys and all. So you can have a look at this. This is something very interesting coming up with the super resolution contrast. And what even Dr. Heta ma'am told, that we are getting the information about the liver lab for the staging of the liver steatosis, then staging of the liver fibrosis, and now we are coming up something very interesting called as viscosity. So viscosity is also now available with our Resona A20, and with a single breath hold, sir, you are able to get all these four parameters. You are able to get the STE, which is your sound touch elastography. You are able to get the viscosity. You are able to get the USET, which is the fat quantification. So all these four parameters and four values, all these things you are getting in one touch, one single breath hold of a patient. So that becomes very easy with our M reference. The technology is called as M reference. So even in the this breast imaging also, breast tumor also, you are able to get the STE, the viscosity, the fat quantification, all these things you are able to get in one touch. And when I talk about the ergonomics, this is how the machine looks like, very robust and very impressive, with a very big monitor, 27 inch of high resolution monitor, 15.6 inch of the touch panel, and there is an X bar which gives you the direct touch to the applications. So this is how the overall A20 looks, and across the world we have started selling, and there are some of the testimonials. They are very impressed with our M reference. They are very impressed with our multi-parametric solutions as well as the contrast resolutions. And in India, our first machine is also installed at Dr. Nitin Chaubal's sir's place. So that is also a proud moment for us. So I think this information will be helpful for you in terms of your practicing. Thank you so much. So yeah, thank you.
Always interesting to know about new technology that is coming in. So we'll just have a quick interval of 5 to 10 minutes. So that, and it's great to know that we have so many people joining us online also. So that's really nice. And there's really lovely coffee back waiting for you and good sandwich as well. So perks of being here physically. And,